really sorry about that. Very, very frustrating. So you cannot see me, right? I am not on video.
You are not
Not on video.
on video.
Video. And Justin, you're going to work the slides for me, right?
I will do my best to work the slides.
Okay. All right, great. All right. Well, let's just, I guess, just go ahead and get started. I will might run a tiny bit over, but I hope not. But thank you everybody very much for your patience. I can't see who's on. Can you tell me how many people are on, Justin?
Right now we have 12.
Okay,
People
great.
tend to join throughout.
Okay, no problem.
Yep. And yeah, I
All
think
right.
there's a turkey leg, the Monday after Thanksgiving as we
Yeah.
all get kind of back to it. So
Okay, gotcha. Okay, gotcha. All right, I'm going to go ahead and get started then since we're a little bit over. But is this people from WashU or are there other people from elsewhere in the country? I can't see who's on.
we are pretty well represented. Some people from WashU. We have people from University of Washington.
Okay,
And I'm going through the list of who else we have. I see Mary Hannah. She's at University of Ottawa.
great. Okay.
And then there's a
Okay.
couple people listed as Zoom users. So I'm not sure who they are.
Okay,
At least
gotcha. All
one.
right. Well, thank you very much for having me. Sorry about the troubles. My talk today is going to be a little bit about the trauma interfaces. And so I am Kathy Marcucci, and I'm doing a three-part talk with two of my colleagues from medical school. We're only going to do part one today. You can do the next slide, actually. Um, and can you move? Okay. And so my colleagues that are doing part two and part three are Carol Bodenheimer, and she is a rehab doc, actually. And she's got fantastic information on rehab of trauma patients. So that's going to be part two. And then part three is Neil Sanson, actually, who is my husband, and he's a psychiatrist. And he is a brilliant clinician, as is Carol, and he has good information on basically further rehab, but sort of the psychiatric interface with trauma, because how a trauma patient does is not entirely dependent on how they do in the operating room. Next slide, please. And I'm not on video today, so there I am. I actually trained at Hopkins. Next slide. And I was also on faculty at University of Maryland, at Penn. I did cases in the VA for many years, and then I did my transfusion medicine fellowship at NIH. Next, please. I am also, this will come into the talk later, but I also happen to have a degree in chemical engineering, actually. So I spent a lot of years of my life right there in Olin Hall at Cornell. Next, please. So what I wanted to do today, if you can see beyond my email there, is talk about trauma as really a family of multi-stage chronic diseases with different etiologies, presentations, and sequelae. So it's not, of course, one thing. I wanted to talk a little bit about the stages of trauma and the principles of trauma and transfusion medicine. And then I wanted to talk a little bit about the interface between trauma and blood banking. That's my main interest for today. And I'm going to talk about blood banking from the platelet level to basically the public health level. And I want to hit the engineering sciences, transfusion medicine, and ethics. And Carol will do rehab for part two later if you guys want to, invite her, and Neil will do psychiatry. And this is an idea talk. I asked Raj what I should talk about, and he's like, we don't actually need to have a lot of data. We just kind of want to hear what your journey is, what you think, and how what your evolution is sort of in thought. So this talk is going to be a little bit about what I'm working on and why. And whenever I say we should do this and we should do that, a lot of that was me and I as I sort of went through my clinical career. Next slide, please. And so these are, this is the watchword, it's bottom line up front. And so the future of trauma and actually all I think of disease is we will soon treat disease with a cell, not with a pill. And in the future, we will all be immunologists. I got down to the NIH where they're doing all kinds of studies. And I said to Harvey Alter, who, of course, is the 2020 Nobel laureate in medicine, and I said, I feel like an immunologist. And he said, we will actually all be immunologists in the future. Next, please. So right now, anesthesiologists give about half the blood that's given in the country. But having been at the NIH for 2 years, I truly believe that this is going to change. And so love the surgeons to death and the surgical oncologists to death. But and I don't know if they know this, they might, but eventually you guys got to believe me from being at the NIH, surgical oncology will eventually become adjunctive and debulking. The vast majority of treatments of diseases will be somewhat partially or fully amenable to the cellular engineering therapies like CAR T and stem cell transplants. And so medical bleeding is going to increasingly compete with surgical bleeding. For blood resources, especially platelets. So the cellular engineering therapies use a prodigious amount of platelets. Actually, it's not unusual at the NIH for somebody on a CAR T protocol over the course of a month to get 100 units of platelets, 100 platelet products. Next slide, please. And so I wanted to present to you guys, I didn't really understand this when I was first resuscitating trauma patients. When I was doing a lot of big cases and in training, I thought that, the stages of trauma were pre-hospital, OR, and the ICU. But actually, I now think that stage 1 are the predisposing conditions. Stage 2 is the acute care, which combines hospital, pre-hospital, and hospital, including the ICU. And then stage 3 of trauma is post-discharge to year 2. And there's a reason why it's year 2. Next slide, please. And so, my friends in rehab medicine and in psychiatry tell me that the goal is not to get a trauma patient out of the OR and the ICU or even the hospital. The goal is to get them to survive past 12 months, all the way through stage 3. And so now my approach to trauma would be to resuscitate, to basically tee patients up for the rehab floor. Next slide, please. And so this is why. We know that about 27% of all patients who survive the hospital die within the 12 months of discharge. And so it's because of age, sex, comorbidities, low income. And basically, if you can't control delirium, pain, and depression, they don't rehab. If they don't rehab, they don't survive past a year. So you've got this gigantic gap in overall long-term survival in patients who do not survive 12 months, actually. And so my friend Carol tells me that in the United States, if you can get somebody, a trauma patient, to the second year post-trauma, no matter how severe the trauma is, it shortens lifespan only by about 7 years, actually. So if you have a very bad trauma and you would have died at 77, you will actually die at the average of age 70. So that's why I've sort of expanded my concept of trauma as longitudinal. Next, please. And so this is a study. I'm not going to quote a lot of data, but this is a paper that basically showed that 27%. This is actually in Taiwan, but they have excellent trauma care and they have excellent blood banking, actually, in a lot of, Western level medical care. Next, please. And so, of course, we know this, but here's a little bit of thoughts from the interface. These are just some principles. Of course, trauma is not uniformly distributed through the population. We know there are at-risk populations for morbidity and mortality. Psychiatric patients do terribly with trauma. Obese patients actually sustain more trauma than the average population. I'm going to assume that most trauma that we're talking about today will correlate with the stay in the ICU. So this is an ICU talk. We know that if you study disability, disabled people in the United States, there is a medical disability, but of course, a large percentage of disability in the country is through trauma, actually. And about up to a third of adults in the United States will be partially or fully disabled at some point in their life. And then we know that trauma and massive transfusion overlap, but are not exactly clinical, although I will tend to use them sort of synonymously today. Next. More trauma interface. Trauma, of course, is not just gunshots, it's broken bones, it's spinal cord, it's TBI, it's hand injury, it's eye injury, it's burns, a special and terrible case of trauma. And the trauma of traumatic burns, the dermatologists tell me, has to do more with the depth of the burn than the width of the burn. So even a small third-degree burn can be very traumatic for the patient, actually. And so, when I was young, I would resuscitate actually for a number. I'm ashamed to say, oh, the hemoglobin is this, the stroke volume is this, the platelet count is this. But I really think now, of course, the better thing to do is to resuscitate and anesthetize, which is a separate talk, to a functional endpoint. So you want to promote wound healing. You want them to, immediately be able to rehab. You want to minimize delirium, which is a devastating post-operative, post-acute event sequelae. You want to maximize pain control and minimize depression and PTSD. So I want to just say that I think that anesthesiologists in the OR and ICU are pretty good, actually. This talk is not to say do this and do that, because I actually think we actually do a pretty good job. Next slide, please. And so these are some of the interfaces I want to talk about. It's like, okay, we're doing a good job. What are we not thinking about? What can we learn from our colleagues? And so there's blood bank, which is a big interest of mine, coags. So it's blood bank bleeding, coags bleeding, engineers and blood, ethics and blood. And I'm going to kind of work around the circle, go back and forth around the right part of the circle. I'm going to leave rehab and psych until mostly later. Next. And so the main question is, of course, how do we improve outcomes and what can we learn from our colleagues at all of these interfaces? Next, please. And so let's talk about the bleeding interfaces. We'll leave ethics aside for now. So how can we better understand blood and bleeding? Do we really understand coagulation? And the answer is, I really never did. How do we resuscitate patients? What does that mean on the micro level to the macro level? And do we understand the ramifications of various strategies? And then there's the question of whole blood versus components. Now, there's a lot of stuff we do in the operating room with a trauma patient. I'm just going to pull out a couple topics to sort of demonstrate, I think, the value of looking at the interface. Next slide, please. So let me this is when I was a resident and attending and teaching and stuff, I just knew the basics. Okay, like the normal hemoglobin should be about 14, and if you take somebody out of the OR, 5 is too low and 12 is too high. Plasma was red and yellow, red and yellow. We'd call up, we want 10 red, 10 yellow. Plasma expanded volume, it corrected PT and PTT. We'd send the coags off. Platelets were just there. We didn't give a lot, back in the day, we would sometimes get them. And, there's your normal platelet count. And that's really basically all I thought about, from the operating room side of trauma. Next, please. But when you train actually in transfusion medicine, which I did do, you realize that blood is gigantically complicated and uncharacterized. And, when you're giving that unit of red blood cells and you're trying to hit a hemoglobin of like 9, I wasn't thinking about the fact that you are actually giving 600 different blood group antigens, of which exactly two have been phenotyped. So when blood comes up, you know the Rh phenotype and you know the ABO phenotype. You do not know the Kell, the Kid, the Duffy. You do not know C and E, which are Rh antigens actually. And so, you're just giving all those blood group antigens blind. Actually, I wasn't ever even thinking about blood antigens I was giving. When you give a unit of plasma, you are giving 20,000 plasma proteins are in plasma. And it ranges the whole way from tiny amounts of troponins to albumin. So look at the difference in the scale, right? So you just cannot believe what's in the soup. It's not something I was actually thinking about deeply enough. Platelets, you're sort of looking at the count, but when you're giving platelets, what you're actually giving are HLA antigens and platelet-specific antigens. And so HLA antigens regulate the immune system. You know, it's the human version of the MHC complex, right? And in the HLA antigen system, there are thousands of peptide combinations that can result in alloimmunization. And emerging therapies, that cellular stuff I was talking about at the top of the talk, actually depend on being able to provide HLA matched platelets. And so I wasn't thinking about the fact when I was giving platelets, and I wasn't back in the day thinking or actually doing something that was going to sort of screw up future cellular therapies. But you're giving a prodigious amount of antigens when you give a unit of platelets. Next, please. So, also when I was teaching and doing a lot of cases, I taught the bleeding phenotypes. You know, you have arterial bleeds, and it used to be aortas. They're now done endovascularly, but they were open. And you would give RBCs and suture. Venous blood would be your liver transplants back in the day. And so it was portal vein bleeding, and you gave RBCs, plasma, and you gave platelets. And then you had cases that you knew were a little tricky, actually. They were mixed vascular, but the patient was cold, or it was a circ arrest case. They were bleeding, which is actually not trauma. But and then you have burns, right? Which where the patient was sometimes hot and sometimes cold, actually, but where you had thermal damage. Next, please. But then I got into transfusion medicine actually, and it occurred to me, what if our engineering friends came over for a beverage? What would they tell us, right? What do they know about bleeding and blood that we don't know actually? And they know a lot. They know about synthetic and bioengineered components. They know about blood rheology. And they will ask the question, are you resuscitating the macrocirculation or the microcirculation? And we actually need, or I need and have been concentrating on these questions. Next slide. So let's talk a little bit about the biosynthetic. So the solution to the blood and bleeding problems are through engineered blood components and biologicals, such as the collagen-based stasis products. So I'm thinking about platelets, bioengineered platelets, and RBC printing. So I hear through the grapevine that the military's got a project. I can't give specifics when they're going to be actually printing RBCs, not like 3D printing, but using a bioreactor and stem cells. So there's not going to be any other way to do it. There's just not going to be enough blood actually in the future to go forward with advances in medicine without the bioengineered products. That's the way it's going. It's not right here yet, but it's definitely coming. And so I was talking to some blood bankers, and they're like, tell your friends, don't get too set on whole blood, and don't forget how to do components, because when the synthetics come online, it will be by component. And then for micro and macro, if you're resuscitating, a transection to the femoral artery, okay, that's microcirculation. But if you're resuscitating the gut, the eye, the brain, or the nerve supply, Then you have to think about microcirculation. Next, please. So there are two guys I want to actually introduce you to, actually. And one I think I already have to Raj. And this is Anirban Sen-Gupta. He is a chemical engineer, actually, out of Dayton. He's now at Case Western. He's a brilliant guy, actually. And he has an FDA-approved biosynthetic platelet, actually, for clotting. Next slide, please. And so it's mimics and amplifies platelet adhesion. It's fully synthetic. He's looking to do phase 1. It's easily portable. It requires no need for blood type matching, and it is FDA approved. So this guy is brilliant. And I did an introduction to Raj, and I think he's actually going to be speaking to you after the new year, actually. Next slide. So the other guy you guys need to meet is actually Mike Graham. And Mike Graham is a chemical engineer. Actually, I saw him in my chemical engineers Cornell. He and I went to the same place. We weren't there at the same time. And he is a blood rheologist. And he's not medically trained. He's an engineer. And he is the top rheologist in the country. Next slide, please. And so he's got this idea that you need to basically have a model of how real blood works so that you can measure how the bioproducts work and are modeled against it, actually. He's looking for collaborations. As I said, he's at Minnesota. He's looking for collaborations actually for anesthesiologists and transfusion medicine docs, actually. He gave us the talk at the NIH. You guys need to meet him and actually hear his talk. Next slide, please. So just quickly, when you think about goal-directed therapies, you're thinking about delivering blood to the tissues, not the number, right? It's just, can we get oxygen where we need to get it? To do that, you have to think about fluid mechanics. Next. So basically, blood is non-Newtonian. I don't know if there are any chemies on this in this talk besides me, but blood is basically non-Newtonian, right? It's a non-Newtonian fluid with suspended particles. That's how the engineers think about it. And the biological rules are tied to the physiology, right? To the physical nature. Remember, non-Newtonian is like ketchup. So viscosity is dependent on applied stresses, actually. So it's like ketchup. When you shake the bottle, you change the viscosity. Next. And so, basically the problem in the circulation is you've got to get a 7 micrometer RBC through a capillary that's 5 micrometers, actually. And this is a little bit of a tricky engineering problem for the RBCs. Next, please. And so in larger vessels, actually, blood is single phase, actually. And that's what you need for cardiovascular health. I mean, you got to get it through the left ventricle, right? It's got to flow like a single phase fluid. You have to move large amounts, every minute around the body. But at smaller scales, if you look at the bottom point, where the blood vessel approaches the size of blood cells, it's not single phase at all, it's multi-phase. Next. And so it will deform actually due to the yield stress action. We've sort of known that, but it hasn't been well characterized actually. And when it deforms, you have red blood cells that are migrate towards the center of the blood vessel. And then you have a cell-free layer actually. Oh, here comes my husband. I'm giving my talk. Okay, 7 o'clock, honey. Okay. All right, hang one second. My husband just came in. And so you have a cell-free layer near the vessel walls, actually. And so you've got RBCs and platelets that tend to reside in the cell-free layers, actually. And then you have, movement of the cells, and you have cross-stream fluxes and wall-induced migration and so forth and so on. Next slide, please. And this is just some more engineering stuff, actually. And I'm not suggesting that you basically master this. I'm sort of presenting this as to show you the deep layers at which the engineers have thought about this actually. And it does have a clinical correlation actually, which we'll get to in the next couple slides. And so, these are two papers not in the anesthesia literature actually. But Carson had a paper and he asked, he noticed that people with low hematocrits had a much higher risk of high grade bleeding, actually. And then this other guy, Plato, saw significant bleeding in 50% of patients, irrespective of prophylactic platelet transfusion. And the question is, why is that actually? Next slide. And they said, we don't really know why this happens. So I sent the papers to Mike Graham, actually, and he actually had a couple suggestions, actually. Now, he was sort of busy in doing grants, so he didn't delve into it deeply. But he's like, this makes complete sense to me. You have lower blood viscosity, and viscosity is going to increase non-linearly with hematocrit, actually. And he also mentioned that you'll have less oxygen delivery at high hematocrits in coronary artery disease. Once again, it's due to viscosity and the flow rates. Next slide, please. These are the papers, actually. Next slide. So I sent this to John Waters at UPMC, actually, because he's sort of interested in bleeding. And I said, what do you think about this, John? Is this clinically relevant to you, actually? And he said, yeah, I think that this is actually very important and relevant. And, the microcirculation works differently than that's say the macrocirculation. And he's like, this could be why our transfusion trigger studies really don't show a difference between a restrictive and liberal strategy. So I'm thinking a lot about this actually, and I think it's worthwhile for anybody interested in bleeding to actually meet Mike, hear us talk, and think a little bit more about this. Next slide. And so, Mike, other people are working on this. Here's blood flow in the microcirculation, but look, it's in the annual review of fluid mechanics, an engineering journal. So we need a summary for anesthesiologists. I'm actually going to start working on writing up a little summary for our community, actually, if anybody's interested in joining. Next slide. All right, so this is another interface, and I had a lot of trouble with this when I got into transfusion medicine. So I get into transfusion medicine, and they're like, all right, Kathy, you got to brush up on your coags. And I had not looked at the coagulation cascade in about, 25 years or so. Never looked at it at all when I was like in the operating room doing big cases. I looked at it on the left and I was like, oh dear God. So I got on YouTube. My husband's like, you're studying off of YouTube? And I'm like, yes, I am. I don't know if you guys know this website, but we all need to brush up on coags actually. And this is the website you want to get. It's kind of cartoony. It's videos and stuff, and it's Medicosis Perfectionalis. So if you need work at the coag interface, this is actually where you want to go. This is the one thing I'm going to say. If you don't do this, actually do this. Next slide. And so this is just an example of, if you look at that headachy thing, this is just what it looks like. He's got cartoons. He's got a little jokey routine he does. There's fibrinogen going to fibrin. That's factor one. We're going to talk about that in a minute. Next slide, please. So I wanted to next look at the trauma blood bank interface. So I've been on both sides of the window. I actually am still on both sides of the window. I consider myself to be both a working TM doc and a working anesthesiologist, actually. And so when we're standing there at the window, this is what the blood bank looks like. It's like, okay, hurry up and give us what we need. Next slide. But if you're inside the window, life inside the window, looking at the trauma ORs, it looks a little bit different. So blood is incredibly highly regulated, like the nuclear, reactors. And when I applied to when I was credentialing at the NIH, the FBI called me. There had been my husband had inherited some money, and it got in the account, and it wasn't that much, but the IRS, so I got a call from the FBI. I mean, blood banks have sections where you need a retinal scan to get in. So it's not like an anesthesia workroom. And so the guidelines for transfusion medicine are developed by the AABB for the FDA, but they're codified as federal law. They're actually in the Code of Federal Regulations. So the rules and requirements are federal law, very much unlike anesthesia. All blood banks are licensed by the federal government. And Raj Nathwani and I are working on a little paper on this, like after the New Year, because I don't think a lot of anesthesiologists understand that. Next slide, please. So blood is the most therapeutic agent in medicine. It's the only thing in all of medicine that is a medication, a fluid, and a transplant. And it is regulated by the FDA and the feds as all three of those things, actually. There has been no solution to donor-based shortage situations. So we were critically short in COVID. We are still critically short. It has not been solved, actually. And the problem is that it is short, but another problem is that it's unstable. Next slide, please. And if you look at the AABB websites, they publish a lot of graphs. They publish every week statistics on collection and donation and stuff. And you can see the little aqua line there, I think was the Las Vegas shooting, and it shows the instability. So, you'll get these big peaks. There'll be a national event actually, and everybody rushes to give blood, but it's often not new donors. It's usually existing donors or often. And so it makes the blood, unstable and critically short later. And so that a lot of that blood is not used actually, or sometimes. Next slide, please. And so I didn't understand when Hopkins or somebody, places an order for blood, you're competing with all the other hospitals in that blood center's contracted distribution network. One time I was at the NIH and I talked to the American Red Cross in Baltimore, giving us 20 of the 40 units, units they had in stock that night. And like, suburban hospital and Bethesda was about ready to kill me. You know what I mean? And there are non-contract customers that will pay a premium actually for units, products, and that also puts a drag on the resources. So if you get blood, somebody else is not getting blood. Next slide. And so, let's talk a little bit about the interface about the critical components. So what do we think in the OR? We think, okay, what's critical is what we want and need and don't have. But what the blood bank thinks is critical are platelets. Platelets drive a blood bank, and of course, type O blood, actually. There is no reserve between supply and demand for either of these products. There's no big pool of platelets or type O blood that can be drawn upon. Not everybody can get the freshest, most highly matched blood. So blood matching is sometimes the least incompatible, which everybody in transfusion hates. Actually, we attempt equitable distribution of blood, but some patient cohorts are more equitable than others. Babies on ECMO get fresh blood, actually. Adults, it's kind of hit or miss, actually. Next slide. So I wanted to just talk a little bit about whole blood, actually, just one topic that's of interest to us you trauma people. So, in the OR, you're like, all right, they're losing whole blood. It makes sense to give whole blood, right? That makes sense. Whole blood is what's collected from donors in most cases, right? So it's probably convenient for the suppliers, right? It's just whole blood, like you're getting whole blood from out of the vein. You're giving us whole blood. It's okay. It's convenient for us working in the OR. It's one bag in the ER fridge, or I guess in some ORs. And the military is doing a lot of the thought work and front running and research and clinical trials for us. So what's not to like about whole blood? Next slide. But if you look at whole blood from the interface with the blood bank, it's a problem. Now, no blood banker is going to absolutely say that the ER and the OR cannot have whole blood. Although if you have, it's my understanding in the Boston area, the blood banks are like, nope, we're not doing whole blood. And there's a reason why. Whole blood is very resource intense. It is not a standard donation. It is not a donor stopping by the bloodmobile event. So those whole blood donors have to be recruited actually. And the FDA, and this is federal law, mandates an 8-hour processing time from the vein to the refrigerator. So you cannot be in a bloodmobile van for 2 hours. Actually, so this is like suburban areas. You can't collect out in Wyoming, you know what I mean? Because you can't drive it to the blood center quickly enough, as opposed to packed red blood cells, which can actually be made from whole blood at any time in the whole blood shelf life, but are usually made anytime up to 24 hours at the time it was collected from the vein. Next slide. So what people don't understand is that, an order for whole blood is a big problem for a blood center. So the blood center on the West Coast, I won't actually name them, said, but they have several trauma centers that they work with. And they're like, we would not be able to provide 100 units of stored whole blood per week to our trauma centers. Like that would be a definite stressor. And yet you would be stressing us and you would be stressing the rest of the blood supply, actually. So we can provide 4 or 8 units a week, but 100, and this is a gigantic blood center, right? But 100 would just be not doable, actually, which I didn't actually understand. You have to be a little bit careful about the military whole blood program. Actually, they're driving their whole blood program forward to support the data pertaining to the walking blood bank. So not stored whole blood, but fresh whole blood, actually. So that's what's underpinning a lot of the drive in the military to do whole blood. And then we have to all be a little bit careful about what's published about whole blood, and even cold store platelets in Canada. They do good science. Their papers are valid, but their public health situation is very different. They have a national blood collection program. We have regional blood collection nonprofits who then price blood as commodities, actually. Next slide. So whole blood is stored for 21 or 35 days, unlike 42 days for packed red blood cells. So that's a problem. The platelet function in your whole blood is pretty much gone after 14 days. And, whole blood doesn't have a lot of platelets, actually. There's not much platelet punch in whole blood. I mean, what good does a 1 pack of platelets do? When is the last time you were ever in the ER and you thought, oh, if I only had 1 unit of platelets, right? And that happens approximately never, you know what I mean? And that 14-day thing, for platelets, it would be nice if everybody could get stored whole blood that's less than 14 days old, but they can't, right? It's not going to happen. The blood business will vigorously protest that. There just isn't enough for everybody. Whole blood also requires its own administration set, or you'll just filter the platelets right out. Next, please. Okay, and so you have to think about whole blood serology. This is kind of important, actually. So whole blood, has to be low titer for anti-A and anti-B. And so that's why you have to identify your donors, actually. You can't just use any donor because, of course, people with type O blood will have O antigens. They will not have A or B antigens, so they will make anti-A and anti-B antibodies, actually, in different amounts. So you have to find people that are making lower amounts of anti-A and anti-B. And so you have to repeatedly screen your donors. It's very administratively intensive. So think about this. If you're giving the universal type for O, right, for RBCs, you're giving the exact opposite of the universal type for the plasma in that whole blood, right? And if you were just giving component therapy and you said, oh, just for fun, we have an AB patient, we just gave them O plasma, you'd be reported to the FDA. But that's what you're doing when you have a trauma patient that comes in, you don't know their blood type, but they're AB, right? Turns out they're AB or B or A, and you've given them type O whole blood. Actually, you've given them exactly the worst thing to give them. Next slide. And so there's also an interface at the transfusion strategy. So in standard massive transfusion protocols are great. I'm all for them. It's now 1 to 1 to 1, 6 RBCs often to 6 plasma to 1 platelet. So, it sounds about right, right? You're given patients do okay. It's been safe. They do well. They get out of the operating room. You're given equal plasma, platelets in the OR. That sounds great. But the blood bank asks us to consider the other red-yellow interface, which is cryo. Next slide, please. So let's talk a little bit about cryo because I never thought about this when I was teaching and doing the big, big, big cases. I never thought about it. So cryo is the insoluble component which is left after frozen plasma is thawed and centrifuged. So cryo is manufactured from plasma, right? So it's very flexible. So you can take, at any time, the blood centers can take FFP off out of the fridge and spin it down, thaw it and spin it down and refreeze it and make cryo. So it's not inexhaustible, but you can have as much cryo as you have plasma. And plasma is generally the most commonly available and least tricky component, actually. So the shelf life is up to 1 year, actually. A large academic hospital, I don't think Liz would mind me saying, and Hopkins generally has about 100 pooled products of cryo in proportional ABO groups, and then about 80 single donor products. So what you see on the right actually is pooled. So it's 5 ABO identical donors or about 100 cc's of plasma. And the cost is about a third of an apheresis platelet product. Next. So let's talk a little bit more about the yellows, actually. So cryo has factor 8, factor 13, von Willebrand, and this is the key fibrinogen, actually. So it has about 3,000 milligrams per deciliter. It's low plasma volume and it's non-cellular, so it's not going to be alloimmunogenic. Next, please. So platelets the cost to the hospital runs about, for random platelets, not HLA match, is about $700 to $1,000 per product, actually. And so if a large hospital has 30, 20 platelets sitting in the little, agitator, they're doing pretty well, actually, versus, what did I say for cryo, 130 products, right? So the platelet shelf life is about 5 days generally versus a year for cryo. Platelets are loaded with antigens, as we said, that cause alloimmunization and possible difficulties for future cellular therapies. And plasma only has about 200 to 400 milligrams per deciliter of fibrinogen. Plasma is also what causes the two deadliest transfusion reactions, which are taco and trolley. And there are people dying of both taco and trolley in this country every year. Next slide, please. So what happens with 1 to 1 to 1, I think, and I've done it, all different ways, is, I talked to some people in the coag industry and transfusion medicine, and they're like, you guys, you give a lot of cellular products, or I gave a lot of cellular products, right? And units of FP, and the bleeding sort of stopped. And I thought, oh, I'm doing fine, actually. You know what I mean? But while I was doing that, actually, I think I gave platelets to where it didn't really work, actually. And so, my husband says, your question when you're giving platelets should not really be what's the platelet count. It really should be, is my patient drunk, actually? And is my patient a heavy cannabis user? And he'll talk a little bit about that in his talk, if invited, because, both of those, intoxicated patients and chronic use, actually kind of knocks your platelet function out, actually. And I truly believe, guys, if you give 1 to 1 to 1, at some point, you're gonna give a component that you didn't actually need. I mean, think about it. How many times have you gone home before we did 1 to 1 to 1, and you said to your spouse, oh, terrible day. I gave 14 units of packed red blood cells, and I only gave 10 units of of plasma, right? And so the thing about 1 to 1 to 1 is I think I have done this, that patients are a little over resuscitated. And it's pretty easy, we've noticed with the 1 to 1 to 1, where the blood bank checks the hemoglobin post-op and it's 12, and that's too high. Or you've given all that plasma to try to stop the bleeding when you could have given cryo, which has much less plasma, because you're giving water, right? You're giving saline, right? I mean, there's no trauma cases where you're not giving, crystalloid actually. Next slide, please. So in the ICU, the patients start bleeding again, right? You've given this cellular product, and your patients are in a low fibrinogen state often. The coag labs, are consulted and fibrinogen is low actually. And your patient starts bleeding, which is bad, right? Because you can't do regional in the ICU, which I actually am very much in favor of. I've noticed that if a patient is bleeding, and the drains are putting out blood and stuff and products are hanging, a rehab is not allowed to approach the bed. And that's actually very bad for outcomes, actually. So remember, I think we're giving too much platelets and too little cryo. Cryo is very cheap, it's very available, and it doesn't cause alloimmunization, actually. And it has the all-important fibrinogen, which is factor 1, which, causes the fibrin clot, which is the structure of the clot. Next slide, please. And here's, in teaching the TM residents and fellows, here's a paper that I use actually looking at, and these are actually in the literature, you guys can look them up, where we're starting to learn about following fibrinogen levels actually, and, post OR. Next slide, please. So this is actually kind of important, actually, and this is the ethics interface, and it has to do with medical futility. And you guys know these questions, actually. Should blood to MTPs and or trauma be limited? Are we using too much blood? Should we define medical futility? Next slide, please. And so these are not new questions. This is a question from 2018 in the emergency room literature. Next question, please. But the important point I want to make is this question is not going away. So I talked to a lot of transfusion medicine people before I was finished my slides, and they're like, please tell your friends this question is not going away. I think it's critically important that anesthesia not let this get away from us. We need to not let somebody else, a different stakeholder, actually make the final call. And this is something I'm talking to transfusion medicine about, actually. Next slide, please. And so, what transfusion medicine wants to talk about is, and us too, is after an arrest, only 11% survive to discharge. It's older patients, male patients, head and neck, torso, chest, and so forth and so on. Next slide. But the point that I'm making to transfusion medicine, which they were not aware of actually, is that the liability is not distributed equally. Next, and resuscitation. Wait, go back 1 second, Justin. I want to make the first point. Go back. And so resuscitating and responding to bleeding is a core requirement of a successful anesthetic. Next, please. So here's the paper that you guys need to fish out and read if you haven't read recently. And I'm shopping this pretty hard to the TM community, actually. And this paper, the bottom line up front is that we bear a disproportionate amount of liability. Next slide, please. And these are just the specifics of the paper. Next slide, please. You guys can review this if you pull the paper. A lot of hemorrhage was in OB, actually. Look at the bottom bullet. The surgeons were responsible for the hemorrhage in 99% of the cases, of course. Next slide, please. And of course, claims associated with hemorrhage had greater injury, actually, with a high percentage of death. Although the surgeons cause the hemorrhage, anesthesia gets dinged for less than appropriate care, actually. And look what we were found. This is closed claims. What we were found liable for: failing to anticipate, communicate, and ensuring that adequate blood was available. Next slide. And look at the payouts, right? So mortality is higher in hemorrhage cases, payouts are more often, and look at the payouts in hemorrhage versus non-hemorrhage cases. Next slide, please. And so, these were the legal findings, right? So although the surgeons are responsible, anesthesia is dinged for lack of timely diagnosis of bleeding, transfusion, and so forth and so on. So we bear the liability for failing to anticipate and fix the hemorrhage that the surgeons cause. So next slide, please. So I'm saying to the anesthesia community, actually, who, by the way, had never heard of the closed claims analysis, never heard of it. They're like, what are you talking about? We never heard about that. Is that it's going to be very difficult, and it should be very difficult for the surgeons and the ethicists to tell the anesthesiologist you can have this much blood and no more as it stands now because of the tort exposure. So I think this is really important. This is where we need to control the interface, actually, because we have the liability. Next slide, please. This is my favorite cartoon. Next slide, please. And then my final interface I wanted to talk about is the interface of transfusion medicine training for anesthesiologists, actually. So there are 54 transfusion medicine fellowships. They don't fill, actually. Nobody knew that, nobody really knows this, but the people that can go into transfusion medicine are us, surgery, OBGYN, emergency medicine, and internal medicine. Next slide, please. And so there are a lot of us. There's 51,000 anesthesiologists. The average age of docs is 46. About 40% of us are over 55, and about of young anesthesiologists, about almost 40% are women. Next, please. And that just shows basically the cohort of anesthesiologists in the older demographic. Next, please. So transfusion medicine training is great. Actually, like us, it's oncology, transplant, pediatric obstetric, you know what I mean? It's a newer specialty that's kind of wide open. The cellular therapies and the cellular engineering is truly cutting edge, actually. So Carl June, I think, is the CAR T guy. I think he's going to win the Nobel. Steve Rosenberg is at the NIH. He's doing CAR T for solid organ tumors. Actually, next. It's a critical issue in global medicine. It's very important for healthcare disparities, research, and work, actually. Apheresis is a part of transfusion medicine, but that's not a problem for us. The pathologists tend not to like apheresis cases because it's too much patient contact, but it's fine for us. It's only 1 or 2 years. It's not physically demanding. Next slide, please. And so there's 4 groups of anesthesiologists who should step over the interface into TM training. And I want you guys to look at number 3, actually. So trauma anesthesiologists, actually, I think should think about training in transfusion medicine, actually, because you are like Steve Frank, you're going to be doing academic and research in bleeding, I would think, actually. I'm sort of in the 4th cohort. I had a complete career and I wanted to basically take what I know and sort of extend it. Next slide, please. And these are the transfusion medicine trained anesthesiologists that I know of in the country. So if there's anybody from Washington University, you might know George if he's still there, actually. And then, of course, there's me. Aaron Hess actually just published a platelet article in anesthesiology, actually. Next slide. And so I think, what I want to do is write up some information about transfusion medicine training to the anesthesiology community, actually. And I want to write up a little bit for the transfusion medicine community, the value of having anesthesiologists actually in the blood bank, which I think is very helpful. I had a job interview just last week, Mass General, and I said, when I was in the OR, I talked to the blood bank every day. When I was in the blood bank, I talked to the OR every day. So this again is something where I think we need to own the interface a little more than we do actually. Next slide, please. And this is my favorite, actually, my second favorite transfusion medicine bleeding cartoon. Are there any questions?
Well, first, I just want to say thank you. It was a wonderful talk. A lot of really interesting points to think about. And I really love the emphasis on transfusion. And I think all of these reasons, especially at the end, is why, I know we're not the only fellowship that does this, but we offer a blood bank rotation specifically for all those reasons that you mentioned and for how involved we are with transfusion. Definitely opening up the floor to questions. I know we're over a little bit on time. One thing I would like to ask in terms of your first couple slides, and this was brought up by someone to me who was actually interviewing for faculty, when we talked about blood transfusions. Should we be thinking about transfusions as a transplant?
Oh, absolutely. In terms of the alloimmunization, I think, um, it's kind of interesting because when I got into transfusion medicine, I was like, I couldn't get the hang of it. I'm like, it's like vigilant, like what's our saying, like vigilance always, And finally it occurred to me that it is, keep the antibodies away from the antigens, except for diagnostic purposes, and what's in the soup actually. So, all that cellular therapy that we're moving towards, I mean, there is, cellular therapies for macular degeneration, right? Every time you give somebody a cell, it's a transplant, actually. So I think that if I could have one concept, it's like you are giving a bucket full of antigens and antibodies, just like a little tiny transplant. So I think it is a transplant.
Should that change kind of our view of it or what we do?
I think, well, Steve Frank says that blood is the best thing if you need it, but it's very dangerous if you don't need it. You know, I think we're going to go back to component therapy, actually. And I think that I mean, I don't know that there's anything you're going to do tomorrow actually in the operating room, but I think as we start to get into personalized medicine and you become when people know what their blood group antigens are actually, which they will eventually, I think that we're going to actually have more phenotyped products actually to try to spare some of the alloimmunization. But in terms of tomorrow or next week, probably not. But in terms of watching the literature and seeing what's out there in the future, I think so, yes.
So that kind of leads me to my next question, which is how should we, I would say, reassess our transfusion triggers, especially in the setting of trauma? Because this is one of the biggest differences between a generalist and someone who practices in trauma. And I feel like our what we've been taught in terms of magic number 7 and things like that don't really apply as well in our patient population.
Correct.
But that's what we have.
Right. So I would say it has to do with the type of trauma, of course. And this is where part two of the talk comes in. Personally, I would I think what's going to happen is that we're going to have individualized rehab medicine programs. So I think it depends on how you're going to rehab your patient. And Carol Bodenheimer has a lot of information about that. Like what happens, like what does your hemoglobin need to be in your oxygen carrying capacity if your rehab protocol means you're getting your patient out of bed the evening they hit the ICU, or even if you're going to sit them up, right? Or even if you're going to start passive range of motion. So I think that I'm sort of against the 7 actually. And, I got, to when I was in the OR, I just used a lot of, sort of end organ, perfusion actually. So I think it's going to be very variable. And I think we're going to have a whole bunch of MTPs for very individualized types of trauma, which the trauma centers can do. I mean, a level 2 can't do it, but the level 1 trauma centers can have thresholds based on the type of trauma and rehab protocol.
I'll stop asking questions for a minute and see if anyone else has anything. And yes, we will definitely be reaching out about getting parts 2 and 3 of this. And I know you brought up Dr. Gupta case, and he was already on our list, Raj. And I have been talking with him, and we will reach out to Michael Graham as well.
Yeah. Well, the thing about, I sent the slides, I'll let you guys go then. I sent the slides to Dr. Alter, right? So Dr. Alter's a Nobel laureate, right? And I'm like, what do you think about these slides? And he said, this is some of the most important work being done in all of medicine. And get into his lab if you can. And I'm like, I'm not a Case Western. He's like, well, I know, but he is looking for anesthesiologists to work with, actually, to do phase 1 trials with. So you guys got to meet him. He's fantastic, brilliant, as is Mike Graham, actually.
Well, as a case grad, I'm very happy to hear that. So,
Yes,
um,
exactly. Okay, well, I'll let you guys go. I'm sorry we're running late. We actually started late, but thank you very much for the opportunity. If anybody wants to work on anything, I'm actually planning on doing a little summary of some of the rheology for the anesthesia community. I don't know if it'll be on the, APSF website, if we'll put it in one of the journals actually. But there's magic everywhere. There's always room for people. So if anybody would like to help me write up some rheology, I'd love to, work with somebody.
I think you may get some emails, especially from
Okay.
WashU real soon.
All
So,
right, great. Thanks, guys. Nice to
thank you
meet
very
you.
much.
All right, thanks. Bye-bye. Bye.
Take care, everyone. This is our last one for the year, so we will regroup in the new year. So happy holidays to everyone and a happy new year.
Great, thanks. Bye-bye.